Hello, my name is Sarah and I am the multiple pregnancy midwife that works at Bournemouth and Csection.
Hello, I'm Amanda. I'm the multiple pregnancy specialist midwife who works at Poole.
My name's Stacey. I'm a maternity support worker at Dorset County Hospital.
And my name's Sarah. I'm midwife at Dorset County Hospital in Dorchester. We both work with the consultant in the multiple pregnancy clinic in Dorchester, and we're going to be talking to you today about what to expect when you're expecting more than one baby. We're going to be chatting to you about what to expect when you come in labour, the signs of labour, what we recommend that you pop in your hospital bag, and we'll also be talking you through pain relief, induction of labour, caesarean section, and what to expect after you've had your babies. Okay, so we've got a few ideas of things for you to pack in your hospital bag. The most important thing to have handy is your maternity notes. Also a red book if your health visitor's given you one or two or more. But those are the most important things to have with you. Then you want to think about the things that you are going to need for your stay in hospital, such as a big towel for you and some toiletries, your favourite choice, whatever you like to use, nightwear, comfy clothes, things that you're happy to pop around the hospital in. We ask you to bring some pads, maternity pads, and disposable knickers, and then things that are going to help you pass the time, so your mobile phone, charger, books, magazines, any snacks that you might want. Do you want to mention things for the babies, Stacey?
Yes, you definitely will need lots of nappies, lots of baby grows and vests, some muslin cloths, some bottles if that's your choice of the way you want to feed your babies.
And the formula milk. Some people bring the starter packs, so it's ready-made formula already in the little bottles, and we can show you how to make those up. You don't need to bring those if you're planning to breastfeed. We'll be giving you the help that you require for that at the time.
And also you probably need to bring a blanket for your baby too.
So signs of labour. Well, they may include having what we call a show, and this can be clear or it can be quite bloody, blood streaked. It's usually jelly-like, and you can have quite a lot, and it can go on for a few days. And it's just generally a sign that things are starting to happen, or it might happen on the day that you actually go into labour. The next thing to look out for are if you're have had tightenings throughout your pregnancy, which is just where your abdomen goes tight and then relaxes, and it doesn't do it in any particular pattern, but it actually starts to build up and actually becomes quite painful, or you start to get cramps, then you need to be phoning the labour line number to have a chat. Also, if your waters go, you may just get a little tiny trickle, and you may think that it may not be your waters going, you're just got a little bit damp down there, but any sign of any waters going, note down the time that it's happened and how much has happened. If you have a big gush, try and work out roughly, maybe it's a cupful or a mugful or more than that, and the colour and the time, and phone labour line straight away. You may not have any tightness as such. You may start with like low period pains, or pains in your back which are becoming regular, and so they might start every half an hour and then gradually build up and last longer. So then call labour line straight away. If you have any bleeding at all, phone, or you're feeling unwell, you just don't feel right in yourself, there's always a midwife to have a talk to, and it's best to call.
So we're going to discuss induction of labour. If your babies are identical, then it's generally recommended that they are delivered by 36 weeks of pregnancy, and non-identicals at 37 weeks of pregnancy. Obviously this will be discussed with you and your obstetrician and your midwife, and an individual plan will be made for everybody. If it's been decided that an induction of labour is the best scenario, then if you are booked to have your babies in Poole, then we would ask that you phone the antenatal ward at 7:30 in the morning on the day that it's been booked to arrange the time for you to come in. If it's Dorchester, then we'll have given you a date and a time when it's booked. When you arrive at the ward, we welcome you in, take you to your bed, and do some general observations of you to check you're fit and well, and also then monitor the baby's heartbeats to check they're happy. Once that's been done, we would examine your cervix to see how close to labour your cervix is, and then have a chat to you about the options available for the way for the induction to proceed. That may be a prostaglandin pessary, or it may be a balloon catheter that can be inserted, but your midwife will explain that in more detail to you at the time. After the induction has commenced, then we will recommend a monitoring of the babies again afterwards, and then it would be suggested that you are allowed to walk around the ward, mobilise, sit on a birthing ball, do what you can to try and encourage labour to commence. Once your cervix gets to 2 centimetres approximately, then it's generally possible for the midwife to break your waters, and that's what would be recommended, and then you would move to a labour room for labour to commence with the oxytocin hormone drip.
So when you're on labour ward, you'll have a midwife that's looking after you and a team of doctors. They'll keep a close eye on you by monitoring your blood pressure and your pulse and your temperature to check that you're well. They'll also keep a close eye on both babies' heart rates by doing continuous electronic fetal monitoring, which is 2 transducers which will be placed on your abdomen, held on by a belt, and it will keep an eye on babies' heart rates to check that they're happy. Sometimes what they do is attach something called a fetal scalp electrode, which is basically a little clip that goes on the superficial layer of the baby's scalp, and that gives us an accurate picture of baby's heart rate, and it's easier to differentiate between both babies when you're in labour. You'll also potentially have something called a cannula in your hand, which is something we would use to administer medications and fluids when you're in labour. You'll likely have oxytocin hormone drip, which we can adjust the levels to increase the contractions if needs be, to get you to establish labour where you'll be having regular contractions, strong contractions, about 4 in the space of a 10-minute period. You'll also have regular assessments down below, vaginal examinations. So you might find that if you came for an induction of labour, you would have that initial assessment whilst you're on the antenatal ward for the induction of labour. But when you're in established labour, sometimes we might do an examination approximately every 4 hours or sooner if indicated, to get a good idea as to the progress that you're making in labour. Also something to mention is fluid intake in labour. So you want to make sure that you're really well hydrated. This might be the case of having IV fluids via the cannula, and also just to make sure that you are drinking enough when you're in labour, and also making sure that you have an empty bladder. So basically you don't want to have a full bladder, which is going to get into the way of baby's head coming down. Another thing to think about when you're in labour is positioning. So potentially depends on the type of pain relief that you might have, but it's a good idea in the early stages of labour to keep upright and mobile, to use the gravity to help baby get into a really good position. If you have an epidural, then it's important to think about not being on your back all the time, so thinking about being lying on your side, or perhaps sitting more upright in a semi-recumbent position. I think Amanda wants to speak to us now about pain relief in labour.
Hello, so okay, you've got the choice of having something called Entonox, which is gas and air, and you have good control of that. You start breathing that in the moment you feel a contraction starting, and you stop as the contraction fades, and the effects of the Entonox actually die quite quickly, so you feel very much in control with gas and air. But you might decide that you want to go on to have an epidural, which is quite a popular one, especially for twin labours, and that would be administered by an anaesthetist. It numbs you from the waist downwards. You would need to have a catheter put in at the same point if you to monitor the urine output. But the epidural is very effective pain relief, and it will also be very useful should something not go quite right with number 2 and they need to perhaps go to have a caesarean section. Then it's very quick to just top that up. So when your labour has got to the point that you're fully dilated, that means that your cervix is 10 centimetres dilated and not covering the baby's head. The midwife will guide you to start pushing baby, and say to you, you can start pushing now. You may have already been feeling the involuntary pushing motions that will build up and build up, so that you will start the pushing. During the second stage, we will be monitoring the baby's heartbeats continuously to make sure they're not getting too stressed. Once twin 1 has been delivered, one of the midwives will just hold on to your tummy and just make sure that the twin 2 is staying in the right position to deliver through that. They will also just get a quick scan while one midwife's holding on and just check the baby's in the right position before you can get to pushing number 2 out.
Sometimes there might be the potential for the need for a little bit of assistance with the delivery of babies. So if that were the case, you would have an obstetrician doctor in the room, and what they can do is if one of the twins shows any signs of slow descent of their head or not an optimal position, or perhaps any signs of distress that they're getting a bit tired in the pushing stage, one of the doctors can do something called a ventouse, where they apply a little suction cap to the top of baby's head just to gently guide baby down to deliver. Or if baby isn't in the best position, they can sometimes do something called a forceps, which is almost like some metal spoons around baby's head that can just gently guide baby down for delivery. Sometimes they may need to do something called an episiotomy when you have that assistance done, which is just a small cut that directs any tearing away from the back passage. Occasionally there is an incident of the occurrence of an emergency caesarean section. So it's about 4% risk that you may have a delivery vaginally with twin 1, but a 4% risk that twin 2 may need an emergency caesarean section. This is on occasions where twin 2 may get a little bit tired and distressed. If this were the case, then if you had an epidural, what they could do is just top that epidural up so it works a little bit higher and take you to theatre for the caesarean section. If you didn't have any anaesthetic on board at all, so you're just using the gas and air, they may suggest doing a general anaesthetic for the caesarean section.
Okay, so elective caesarean sections. If the plan's been made that the safest option for you and your babies is to have a caesarean section, then again that will be discussed with your consultant and your midwife, and you'll be given a date and time to attend for your caesarean section. We ask that you come in, we make an appointment for about a week before the planned caesarean day for pre-assessment, and that involves just a general check over of you, some blood tests, swabs, nothing to be concerned about, just a general health check over before the operation, and you'll also then have a review with the anaesthetists and be given an antacid to take on the evening before and the morning of your surgery. We also ask that you are nil by mouth from midnight on the day of your surgery, apart from the antacid that you would take in the morning. When you arrive on the ward, you will be greeted by the midwife and also seen then by the obstetrician who's going to be performing the surgery and the anaesthetist to chat through what's going to happen that day. We give you a gown to change into. We ask that you don't wear nail polish on your fingers just to aid the monitoring. So a member of the team will insert a cannula into your hand or your arm, which we give IV fluids and also medications that you may need in the surgery. In theatre, you'll have a spinal anaesthetic, which is similar to an epidural, if that is the method that's been chosen for your pain relief for the operation. Some ladies choose or is recommended to have a general anaesthetic, but again, that will have been discussed with you beforehand. If you're going to be awake for the surgery, which is with the spinal, then you can have your partner attend in theatre with you. If you're going to be asleep, then he or she would need to wait outside. There will be some drapes put up so you can't actually see the operation occurring, but once babies have been born, they can be shown to you, either the drape lowered or the babies brought round so you can see them as soon as possible after the birth. Sometimes the babies need to be taken to the specialist baby doctors, the paediatricians, for a little bit of a check over, but again, all of that would be explained to you at the time. We keep babies with you as much as possible. And then after you've had a brief period of recovery in theatre and you're all well, then you'll go back to the ward all together as your new family.
When your babies are born, the midwife will put labels on each ankle. These will need to stay on until your babies go home. This is just to identify them with you. Wherever possible, your babies will stay with you at all times. Midwife and maternity support workers will be there to care for you and your babies and to give general advice for you and the babies and their feeding.
Hopefully, most babies will be able to stay with you on the ward. Occasionally, some babies need to go to the special care baby unit or neonatal intensive care unit if they require some additional support, such as for reasons of prematurity. Again, if this is the case, everything will be discussed with you at the time. Poole have a transitional care unit, and Dorchester have a rooming in area with 3 single rooms for parents to stay if their babies are on the special care baby unit. You would still be receiving care from midwives and also the support team in those units. Once you and your babies are discharged from hospital, then the care will continue in the community with your community midwife, and also the health visitor will then take over. We've included some useful links and websites here for you to have a look at. The Twins Trust is a really useful guide. You can subscribe to the Twins Trust if you want some additional benefits, but actually just by registering with them, which is free, you can access a whole load of really good, useful information from them. There's also some links on this page for local support too, all of which is helpful when you're expecting new babies.
Thank you for watching the video. We both hope that you found it useful. If you have any questions at all, please speak to your community midwife or call Labour Line. Thank you very much.